So let's open it up to the panelists and see what questions you have. Maybe we could ask you to raise your hand, and it would be great if you'd be happy to say where you are, who you are, where you're from, and what your question is. It's open for discussion and comment. While we are waiting, I might just ask Jonathan. Jonathan, I was interested in the significant difference in the repair costs of the bronchoscopies for the ICU in different settings. What are the sort of thoughts around
that? So I agree. The repair costs are striking among the limited data that are there. They are all higher than I thought they would be. And some, namely my own, were significantly higher than I anticipated. When we looked at our center, we looked at bronchoscopies that were performed in the ICU setting only. And we did so over a 3-year period. Those bronchoscopies were performed by trainees and by different attendings, depending on the ICU. So at least in my hospital, the neurocritical care or the cardiac critical care folks or the surgical critical care folks all perform their own bronchoscopies. And so there are varying levels of experience, especially when it comes to trainees. And then how we have our setup structured is we have a central repository consisting of about 7 bronchoscopes that are used kind of every day, all day. They are reprocessed, of course, after they are used, but there's no ownership per se. It comes from a central supply, and then you don't get feedback if the scope is damaged during use. And so I think there's a lack of appreciation or awareness among users that may lead to less careful usage.
I would concur with that. I guess any of us who've seen it, it's inevitable that potentially less experienced hands leads to increased risk, but you have to mitigate that. And in certain situations, one could almost pseudo legislate and say, look, this is a complex procedure. It's more likely to lead to risk, a tracheostomy, for instance. That's going to be where we're going to use the single-use scope. If you need better visualization and there's concern about an underlying malignancy or something unusual, maybe that's where, from a diagnostic perspective, you want to use the better imaging of the reusable. But these are the, I guess, the refinements that where we are going to have to think about as we adopt this symbiosis of reusable and single use.
Exactly.
Yeah. We have a question here from Fotios, who asks, is it safe and meaningful to reuse a single-use bronchoscope on the same patient after manual cleaning? It's a great question because it's a vexed issue. These are single-use for the reasons that we said, and they are developed as such. And if you just think about this, there is some limited data publications from Brendan McGrath and others that have bench tested these scopes that have been left out and haven't been cleaned or have been cleaned. And there is a definitely significant increased risk of persisting contaminated bacteria within I think an 8-hour period of sedentary use. Now, the question is, what if you flushed and cleaned these single-use bronchoscopes? And the answer to that is we do not know, and we don't have robust evidence. And I think one of the rate limiters to good practice needs to be that we don't necessarily perform best practice even with the single-use scopes. I've seen it in our own institutions that they're left out there for a few hours afterwards. No one flushes them through, no one wipes them down, no one necessarily leaves a must be thrown away by this time indicator. And I think that is a really important point. And if it was me as a patient, I certainly wouldn't want that being reused on me a few hours later. Who knows what's in them in that working channel. So I think the correct answer is it needs to be thrown away. But I think the answer to your question is there isn't evidence to robustly suggest whether or not one can leave them out for a certain period of time after cleaning. I don't know if Sonali and Jonathan would like to sort of make comments on that, because it's a really important point.
I'm in agreement with you. Everything I read in the literature is appropriate to what you were saying. The scopes tend to sit out for a while and they get a lot of biofilm. And although we may think we're doing a good job, like I showed you, of cleaning scopes, we really aren't. And I would be very wary of using a single-use scope in another patient as well. And in fact, the recommendation is not to even use the same scope in the same patient hours later
Correct.
or the next day. It is truly single use that one time, and to then get rid of it.
Yeah, for sure. And, otherwise it might only be a matter of time before we get, those safety alerts as a result of recurrence of infection in the same patient, or a new ventilator-associated pneumonia in the same patient. Which, of course, leads into the question about health economics and costings of the burden of plastic that is being thrown away straight away after its use, and where we are and where we sit in terms of the sustainability goals. And I don't know whether, Sonali, Jonathan, you have any sort of thoughts on that. I know our industry partners, as Sonali, you said, are working hard to try and find solutions, but as I understand it at the moment, there isn't in a sense, these are mitigating solutions. So they will buy back carbon, if you like, from another program, but these are still disposed of through incineration or other means. Any thoughts on that?
No, again, like I said, I did try to look in the literature. There was the one paper that I found that I presented. And then in speaking to a lot of the companies, they're very aware of this. I know Ambu is actively working on a program right now that hopefully will be launched very soon. So I think they're aware that the scope usage is going to go up. They're very environmentally conscious. And so I'm hoping that it's something that will be addressed quickly.
Yeah, I think based on what I've, read myself and what I've, seen is I think that there is a more tangible environmental impact when you're talking about single-use scopes, and that you have this, this plastic device that you're gonna throw out. But I think people fail to realize all of the energy and detergent and supplies that go into reprocessing reusable scopes. And so when you compare those, side by side, based on what I've read, it is actually the reprocessing of the reusable scopes that has a greater environmental impact than disposing of a single-use device. And that's at baseline. When you add in, recycling programs on top of that, the difference is clear in that single use is probably the more environmentally friendly path.
Yeah. And just in terms of, the interesting question about how procurement and, and different organizations, how procurement, what that's going to be based on. It's usually based on a lot of the stuff that Jonathan has already alluded to. But then how do you how does one balance that period of time of transitioning where you will be using both types of system, right? Which will inevitably lead to an increased cost upfront until someone has made that decision to wean down and off the reusable system in that particular environment. And that's a challenging one, right? I've seen some calculators online to sort of facilitate that type of work, but I think that's that's where the conversations need to be clinician, procurement, purse string holder, and industry, right?
Yeah, I think for a while there's going to be a balance that we have to strike between which cases we're going to do with a reusable scope and which cases we're going to do with a single-use bronchoscope. Up until very recently, in Europe and soon to be in the U.S., we didn't have single-use bronchoscopes that were capable of doing all of the interventional work that we do. I think we're probably getting to that point, or we're possibly there now with some of the latest model scopes. And so for a while we're going to kind of have to balance things out, but eventually we may shift to a complete single-use option. It just depends. I think that there are certain patient populations, like Sonali mentioned, lung transplant patients, other immunocompromised hosts, where we probably should be using single-use products preferentially. And then, eventually we'll be able to incorporate them into our more advanced procedures as technology improves, which I anticipate will be in the near future.
Yeah, I mean, that's a really exciting prospect, isn't it? And in fact, Manaldi Razmin from Indonesia puts in the chat that in certain situations, those special victim conditions, landslides, earthquakes, you're absolutely right. This kind of portable technology is really needs to be promoted, developed. Pre-hospital care, for instance. This is exactly the kind of area where, in my own sort of burns inhalation injury area, these are the kind of things where one could actually find important niche uses for it that are actually basically better than nothing, right? So for sure. If we just get back just briefly to the technology, are we happy that we are that the quality of the images, which was for so long the concern in single-use bronchoscopy, are sort of at the level that we would be happy with in the interventional bronch suite?
I think they're getting better and better from what we see. Every generation of a scope that comes out, the imaging just gets better and better. And I think we're at a point with some of these next generations that are coming in where we can plug them into the current bronch suites that we have with all the screens and HDR screens. For those of us who have recently updated our suites or been lucky enough that it will plug into all of our HDR screens and actually give us that good quality imaging that we're used to. And so I just think that we're going to be at a point where they're going to be very equivalent.
Yeah, and the connectivity, as you were alluding to, is a really important aspect as well. I know the companies I speak to, that we all speak to, the moves towards Wi-Fi, Bluetooth, and so on. So long as the GDPR rules are made allowable and permissible, I think they're all working on those. Yeah, so just to conclude, a couple of questions about education and where we see and training and then research. Where do we see the important value of single-use scopes in helping to develop training and education? And what kind of research studies do you think would be worth doing with these scopes?
Education and training, yeah. You mean directly to the fellows. So I'll openly say most of our scope damage is probably because of the fellows. So But like I said, my first year fellows, at least when they first start out, they learn bronchoscopy, which is basic. They learn BAL, transbronchial biopsies, and that happens to be all our lung transplant population. And so I think for me, when I've been thinking about how to incorporate this in as the next generation scopes are coming in and we need to think about bringing them in, to me, that probably would be the first place I would be starting, is there. So I think then as the scopes get better and better, and you get more confidence in being able to do the high end work that needs to get done, like the airway tumor obstructions that are in the airway, and you have that good control and vision that you need when a bleed happens or whatnot. I think then you'll easily start transitioning into that, and then hopefully we'll be getting EBUS scopes very soon, and that causes even more damage than your regular scopes with the fellows. We won't have to worry about those punctures anymore with the needles, destroying the channels. So I think it's a very easy way to incorporate it into those practices where there are a lot of fellows in education. I don't know, Jonathan, how do you feel about that?
Yeah, I would agree with everything that you said, Sonali. I think that single-use products are hugely beneficial for training, in that you don't have to worry about damages. And then I think they also facilitate training internationally, where they may not have lots of reusable equipment. So it facilitates a broader reach, broader exposure. So I think it's just making bronchoscopy more accessible to more people globally.
For sure, I think that's exactly right. I resonate with all of those comments. And from a research perspective, final question, I guess, is there a particular study that you would like to be done? I'll sort of mention my I guess uncertainty here is I don't really have a sense of where the single-use scopes are being used. I as you've seen, they're being bought more and more. So there's an exponential growth in terms of market value, but I don't get a sense of the usage, the drill down usage, in the ICUs, in the OR, and regionally. And I would be interested in that to understand where the gaps are, such that one can focus attention for these technologies in appropriate areas. That's my own sort of interest.
Yeah, I think in our own institution, what we've seen, and I think COVID was the big changer of this for everybody, is that ever since COVID hit, we basically no longer in our ICUs or our ORs are using reusable scopes whatsoever. I don't even know if the fellows know where the tower is anymore that's hidden in the room, in the ICU. If there's something high end, we're the only ones, the interventional pulmonologists are the ones who are taking our reusable scopes and our towers to the bedside, but they're just grabbing, these disposable scopes and doing whatever they need to do. And every anesthesiologist now is just using disposable scopes for all their intubations and whatnot. And when I get called in to help them, if there was a mild bleed, that is what they are handing me. So yeah. I think that has basically been a complete switch in the past 2 years. Yeah. And I think that's just because the quality of scopes have gotten better and better and better, and people are more comfortable with them.
Right.
I think from my standpoint, so I agree with everything Dr. Sethi said. I think that there's this pervasive mentality that single-use scopes are an inferior product. And I think that historically they have been, but with the latest generation, I think that that the gap is narrowing and may in fact be gone. So what I want to see from a research perspective is I want to see that the single-use products are just as good as reusable products. And I think that, how we can accomplish that on a small kind of realistic scale is pick a given procedure, do a series of cases with the single-use scopes, do a series of cases with the reusable scopes, maybe randomize 1-to-1, and see if there really is a difference. Is the complication rate higher with one? Is one taking longer than the other? Are the outcomes different? And I think that we'll be surprised how minimal the differences are, if any. And I think that will go a long way to dispelling some of these preconceived notions.
Absolutely. And yeah, so go ahead, Sonali, sorry.
Yeah, no, and another one is with regards to what Jonathan is saying. I know you gave that one study on 700 scopes and what the cost was. And a cost analysis study on, is there a breaking point of a certain number of procedures that your hospital performs that at that point it's no longer beneficial? What is that breaking number? Is it 1,000? Is it 2,000? Is it less than 1,000? Like, I think that would be very interesting for a lot of institutions that do a lot of high volume bronchoscopy, because I feel like that's the pushback a lot of places are going to get. So if we had some kind of economic breaking point of this is the number of bronchoscopies, at which point it's no longer efficient to use it, I think that would help all of us when we're moving forward too.
For sure. And there is, I'll try and post it later on, there is as I was alluding to, a sort of a calculator that some German folks have sort of created to try and sort of assist with that breakpoint calculation. We have some comment. We have some questions here. One of the questions was from Singapore, the University Hospital, from a respiratory therapist, Billy Garosp. Most of my consultants prefer to use reusables because of stronger suctioning, good graphics, suggesting that the angle is different from in the ambu in terms of viewing angle. Any improvements? I would say yes to all of those. From my own experience, the scopes are certainly bench testing them very equivalent to some of the reusable scopes that we use. Certainly for standard procedures, simple diagnostics, infection, lobar collapse, etc. There was a question about, is it any good for the ambuscope for stenting procedures? And to that, and I'll ask your comments, guys, to that I would say hasn't been tested yet. And I've certainly not tried putting a stent in using an ambuscope or a Boston or any other single-use scope.
I haven't yet either. Maybe with this next generation Ambu 5 scope that comes out, when we can get our hands on it, certainly can try, but haven't actually used it in that situation yet.
Yeah, so I haven't used single-use products for advanced interventional bronchoscopy procedures, but we did do some bench research comparing the ability to put different products like stents, balloons, etc., through some of the different single-use options that are out there, and then looking at how those affect flexion, extension, etc., relative to their reusable counterparts. And I'm still waiting to hear back about the abstract for that for the WCBIP meeting, but hopefully I'll be able to share those data with everyone at that meeting. So stuff's in the works.
You're going to keep us guessing.
For now, yes.
Okay. All right. Well, we're looking forward to hearing. And there was a question from Nihad Osman about how long you can keep one of these single-use scopes out and then reuse it. And I think we would refer you, Nihad, to the conversation that we had earlier on. I don't think that they should be left out and reused. And if this was a new tracheostomy, for instance, you may wish to flush it, wipe it, and keep it there for some minutes, an hour in case there was a complication that you needed to deal with. But I think beyond that, and I can't give you an exact timeline, one just has to be aware that biofilm and accumulation of bacterial load is developing all the time. So remember, they are single use, not even single patient. reuse. Yeah. Okay, well, I think that is, let me just see, are there any other questions? I think that's probably a wrap. So I wanted to take the opportunity to thank Sonali, Professor Sethi, and Professor Kerman for a fabulous discussion and excellent talks today. I've learned a huge amount, and thank you to the panelists, and thank you to the contributors and to the listeners. We want to thank Michael Mendoza from WABIP and to our friends at Ambu for making this possible. So with that, I think there's going to be a recording that will be available to everyone. Wish you a good morning, afternoon, or evening, and have a great day. Take care.
Bye, everyone.